Hello, good morning. I'm Ashok Rokade, consultant rhinologist and anterior skull base surgeon from Winchester and University Hospital, Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to the second day of inaugural Winter Global Rhinology and Skull Base Surgery Webathon. Global Rhinology Network is a non-profit organization with a mission to foster surgical education in rhinology and skull base surgery. We have successfully hosted annual multi-center live surgical webcast, the LION-ESS, since 2014 in collaboration with LION Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We had hugely informative and engaging 15 sessions on endoscopic sinus surgery presented by eminent rhinologists and skull base surgeons on day one. We'll be having similar sessions today focused on anterior skull base surgery. This event is hosted at the Global Telemedicine Studio of Professor Wilco Grolman in Utrecht, the Netherlands. It is supported by Medtronic and Karl Storz.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
Sean Carey is a consultant ENT and skull base surgeon from Newcastle on Tyne. And can I request him to host Christos Georgalas for the next presentation, please? Thank you.
Morning, Ashok. Can you hear me okay?
Yes, we can.
Good, okay. So yeah, welcome from a wet and cold northeast of England. So it's a pleasure to hand over the mic to my friend and colleague Christos, who's probably sitting in a nice, warm, sunny environment. No, it's okay. We don't need to see. We've got a fair idea. So yeah, Christos is or trained, I should say, in Athens and then in the UK and in the Netherlands before taking up post as faculty at UMC in Amsterdam, where he developed a skull base program there before moving back to take up a specialist position in Athens, where he is at the moment. So Christos will be well known to you. He publishes prolifically, he develops courses, and he's been very closely involved clearly in the development of this innovative digital online program. So Christos, welcome this morning, and we look forward to hearing what you're going to tell us about the pituitary. Thanks very much.
Thank you very much. Thanks very much for the very nice introduction. Indeed, the weather here is sunny a bit today, but it's not too warm. So let me share the screen, and we are here. Let me see. And play. Yes? Is it visible?
Yeah, all good.
Okay. So, yes, I must say that all the credits for organizing this amazing feat of endurance of 2 days, the 2-day webinar should go to Ashok Rokade, who had did all the hard work, and we really are impressed. And I can say that my presentation, I was given a presentation on pituitary, suprasellar, and cavernous sinus lesions. And I will start with some basic, not anatomy, but pathology. It's from a chapter from our book, Rhinology and Skull Base Surgery. And basically, let's look at what types of tumors we get in this area. So we can get tumors. We can get mostly benign tumors. And of course, we all know the commonest one is the pituitary adenoma, either secreting or non-secreting adenomas. Then we have craniopharyngiomas, which appear more often in children, but we can also have them in adults at any age. We have meningiomas, we have gliomas, and then I had a couple of cases of metastatic tumors, actually both of them with metastatic tumors from mammary carcinoma. Chordomas usually extend lower in the clivus, but sometimes they have extension superior to the sella. And also we had a case of lymphoma in the pituitary, in the sella. Cysts are a different story. Of course, the craniopharyngiomas can be cystic, but usually a cystic lesion with no, let's say, with no heterogeneous content, which is hypointense, is very suggestive of eruptive cleft cyst. And then, on the other hand, the dermoid cysts have content which is more heterogeneous and more and less cystic. We can also have inflammatory granulomatous disorders, such as an abscess. And we had a patient with hypophysitis in a child, presented with panhypopituitarism, with complete pituitary gland failure. Histiocytosis, you can read them, glandular hypophysitis, amartomas. One of the most riskiest diagnoses, and also we have seen a case with the giant carotid aneurysm that presented into the sellar region with a large medial extension. And of course, if someone who was not very careful or could not read the radiology adequately, he would get them into trouble. And pituitary apoplexy is nothing else than bleeding, an acute case of and sudden enlargement of a pituitary tumor as a result of bleeding within the tumor, in the adenoma. Now, this, as I saw from the poll, that most of the people who are attending this, were watching these presentations, are ENTs. I think 91% are ENTs. This may be very obvious for the neurosurgeons, but for me, at least, when I started doing this kind of surgery, it was something new. And by the way, I think it is important that the ENT doesn't take just a role in the surgical treatment of these lesions, but understands their physiology and understands their management. So pituitary tumors in itself, the presence of an adenoma doesn't mean that one should operate. And imaging, the first part, of course, beyond the signs and symptoms, would be the imaging. MRI is critical, thin slice, 1 millimeter MRI with contrast. And following imaging, an endocrinologist should assess these patients and assess whether the tumor is functioning, it's a functioning or non-functioning adenoma. The more critical, the single more critical question is whether it's producing prolactin, and specifically if the prolactin production results in a significant elevation of prolactin levels with HPR more than 100 micrograms per ml, we're talking about a prolactinoma. A smaller increase in a smaller rise in prolactin could be the result of pressure, doesn't in itself prove the presence of a prolactinoma. Prolactinomas is the one functioning tumor that is always by default treated medically initially. In non-functioning adenomas, one should treat the ones which are large, have a mass effect, and are compressing. As I said, surgery is the mainstay of management for adenomas that cause compressive symptoms, and sometimes for adenomas as well, it's not written here, that produce symptoms from pituitary insufficiency. while patients with plaquenomas do it primarily medically, as I say. And it's a different type of surgery that one would do for secreting tumors versus non-secreting. For hormone-secreting tumors, the complete surgical resection should always be the aim. Especially difficult in cases of tumors secreting ACTH in patients with Cushing, where the cure rate usually does not exceed the 60 to 70%. Now, I'm not going to go a lot into anatomy because we had an excellent presentation earlier, so I will not be repeating. The keys, as you can see in the slide, the keys to visualizing the sphenoid window, the cellar compartment, are the internal carotid arteries, and especially the parts that are coming medially and come laterally to the pituitary gland. These are the parts of the carotid artery that project more anteriorly and more medially and are the easier ones to damage during surgery. And this slide is an old slide, but I find it very always informative in terms of showing the difference between microscopic and endoscopic approach. And what I mean is, this is a patient, an endoscopic view of the sella in a patient with a recurrent pituitary adenoma. In the center, you can see the area of scarring, which was produced from the previous surgery using a microscope. And this is the type of bony resection that we aim to do when we are treating patients with pituitary adenoma in most cases, which, as has been described better from people other than me, it should reach the lateral carotids and superior and inferior, the superior and inferior carotid sinus, the four blues, as been very eloquently described by the Pittsburgh group. And this is the view that one should get after the bony removal. And you can see again the scarring in the center of the dura. And this is a typical patient with a cystic non-functioning adenoma. And you can see the heterogeneous appearance, and that makes it different from, of course, a Radke cyst. We start by gently retracting. Sometimes we try to preserve the mucosa over the anterior wall of the sella, the bony wall of the sella. The bone, as in this case, is usually very thin. It's thin, especially in case of macroadenomas. It's not the case in microadenomas, especially Cushing microadenomas, or adenomas that have to do with which produce growth hormone, where we see very often a lot of bleeding and a very thickened bone. We always cauterize the dura. We want to, if possible, to minimize bleeding. You saw earlier, again, in the beautiful presentation, the venous plexuses that exist in the anterior wall of the sella. And then we use this either a scissor or, as in this case, a very small knife to open up the wall of the sella. We'll put a bit earlier. Material, which is the adenoma material, is sent for histology. We enlarge the opening. We try to create a window which is based, a flap which is based superiorly. And then using the typical instruments, we use the Capablanca set. We remove the tumor. You know that the tumor has been completely removed when you can visualize the arachnoid superiorly and you see the arachnoid coming down from superiorly to inferiorly. And with the endoscope, you can visualize, of course, your lateral limits of your removal with both cavernous sinuses. And let's put a bit further. And when you get a complete resection, then we can bleed. Another case is this macroadenoma. Again, you can see it's not encasing, but it's reaching the carotid arteries on the right and the left, and you can see the pressure that it produces on chiasma, as you can follow the optic nerves superiorly. And this is the view from the right nostril. We use a kerison, and we also sometimes use a drill to completely remove the septa from the sphenoid. And it's very critical in this case to have, of course, a good view of the anatomy of the carotids and, of course, of the bony septation of the sphenoid. The material of the adenoma is usually this kind of semi-solid material, which can be suctioned and can be gently curated. We use neuronavigation. not to confirm that we have completed our resection and to guide us through the surgery. It's something that we have been using routinely since we started doing this type of surgery, and we find it always very useful. And actually, the more we use it, the easier it is to set up. In case where there hasn't been an intraoperative leak, there is no need for reconstruction. And this is the postoperative view. We want to see this kind of filling up of the cavity where the adenoma was with CSF, as you can see on the right side. And on the sagittal, it's more obvious that the pressure on the chiasma has been relieved, and the empty cavity has been filled with the lower nerve of the arachnoid and has been filled with CSF. Now, some adenomas produce a lot of this, of course, have been cases of straightforward adenomas. Some adenomas present more of a childhood, such as this young lady that presented with sudden episode of hemianopsia. And you can see that the adenoma on the right side is completely encased in the right carotid artery. In such cases, the typical transphenoid approach will not be enough, as one has to reach more laterally. So you can drill through the pterygoids and do a transpterygoid approach to get more lateral access, lateral to the carotid. And then, of course, we'll have cases where the adenomas extend superiorly. And I'm not going to go into details, anatomical details, because you heard it from the previous presentation about the tuberculum cella and the planum sphenoidale. And this is from the chapter that we had the honor for this, of course, well-known names to write for our book. And the benign pathologies, what kind of pathologies you see in these areas? Well, there are developmental pathologies, as you can see. And usually ENT, let's say, pathologies which are dealt by ENTs, such as meningoencephalosis with CSF leaks. And then you have pathologies which fall in the realm of the neurosurgeries, more often, such as meningiomas. And then again, you can have the juvenile angiofibromas. You can have, more importantly, we have pituitary adenomas that extend suprasellar, with significant suprasellar extension, where you need to drill the planum sphenoidale and the tuberculum cella to get access there. While in some cases, you can even have pathologies such as these malignant pathologies, which extend in that area. Now, this is an example of a pituitary adenoma. The extension was, the extension above the cella was significant. In such cases, it would be very difficult, although, of course, it depends on the consistency of the tumor. Some tumors are softer than others, and as the tumor is removed from its lower part, it tends to collapse. It brings the arachnoid down with it, and you can achieve a significant resection. However, in our experience, most of these cases, you need to get the angle right towards the upper part of the tumor, which means that you have to drill through the tuberculum cella. And this is what we did in this case, and this is the postoperative result. You can see the nice inverted C that is produced by the vascularized nasoseptal flap, enhancing. And this is a case I did with Dr. Van Furth, the neurosurgeon I was working with in Holland. A typical tuberculum cella meningioma with pressure on the optic nerve. And this is the question that was discussed earlier. This, of course, is one of the ways of doing these meningiomas. Let's say the nice thing about this is that you go beyond, under the chiasm, so you can visualize, and theoretically at least you can protect the small arteries that supply the chiasm from below. And the reconstructions that is done here. And this is what you saw earlier again in the anatomic photograph, but you can see them here as well. This is the intraop photograph. And you have this beautiful view of the anterior cerebral artery, the anterior communicating artery, the optic chiasm, and of course, most probably the gyrus rectus. And the small arteries can be, the small arteries that you can see here can be preserved in this way. And following surgery on the previous patients, the meningioma, the decompressed chiasma. The same approach, the transplanum approach, can be used for craniopharyngiomas, such as in this patient. Now, craniopharyngiomas are essentially congenital lesions which have both a cystic and a solid component. The problem with these lesions, as again the neurosurgeons will know better than us, is that they tend, number one, they tend to produce, to be associated with significant pituitary and problems, with endocrine problems, insufficiency, the press on the optic chiasm superiorly, and the result in reduced vision. And because of their consistency and the nature, sometimes the cyst, the wall of the craniopharyngioma, can be very tightly attached to the surrounding structures, and its removal can be extremely dangerous. So depending on the situation, complete removal sometimes is not the goal, and one should aim to achieve a balance between, let's say, benefit and harm in this kind of surgery. This is the previous patient, and we're looking at the right nasal nostril, creating the nasoseptal flap, the typical case using a Colorado needle. And we know that we have to raise the flap if we deal with tumors that are intradural, that go beyond simple pituitary adenoma. The elevation, because we'll need to reconstruct the elevation of the flap, removal, as you saw earlier, of the bony part of the septum. Now drilling, here we're drilling on the pituitary, on the anterior part of the sella, between the two carotid arteries that here can be nicely visualized. And in these cases, you have to use both hands, which means they can be done safely only with a combination of two surgeons. And using the drill, again, to take the lateral parts of the bony window that we will have in order to access the tumor. In most cases, we don't have this nice bony flap that is produced. In most cases, the bone is removed, but in this case, we like to have this. And now you can see nicely here you can see the adenoid, the pituitary gland, and above it, the part of the dura at the level of tuberculum cella and planus sinoidale, which has been cut. We are working above the pituitary gland, and this is the craniopharyngioma with small vessels that are surrounding it. And above the craniopharyngioma, you see the small arteries that you heard earlier described. These arteries supply the optic chiasm, and some of them also supply the pituitary gland, and it's important, if possible, to get them preserved. We keep on removing the content of the craniopharyngioma. Of course, the big question is beyond the content if one will remove the capsule of the craniopharyngioma, and the answer is it depends on how much attached, how tightly it attached is to the surrounding structures. Anatomically, the pituitary, the stalk of the pituitary gland is preserved, but that doesn't guarantee the functional integrity of the gland. The anatomical integrity. In many cases, the pituitary function is significantly depressed. In this case, as it was not tightly attached, we were able to achieve a complete removal, including the surrounding the capsule of the craniopharyngioma, and we can visualize the empty cavity. And finally, the reconstruction is done with a combination of fat, fascia, and flap, as we learned, using fascia lata and fat derived from the same area. As I said, the fascia lata, and on top of it, the nasoseptal flap for reconstruction. This is the post-operative result with the enhancing inverted C that is produced by the nasoseptal flap and the macroscopic removal of the tumor. Same case in a craniopharyngioma, which is more or less, it's much less solid, has much more cystic components, and also it appears in a child. I'm not going to go through the video, but this was the initial view, the decompression. And as I said earlier, the preservation, anatomical preservation of the pituitary stalk, which doesn't always guarantee, but sometimes can be associated with preservation of function, and visualization of the third ventricle, and the small arteries feeding the chiasm, which, as you can see here, has changed its shape. It has become, from round, has become compressed from the pressure, and hereafter, complete decompression. And the anatomic, the MRI following surgery, again with the reconstruction of the inverted C area. More anteriorly, but that's not my scope, will be transcript from approaches, such as for this meningioma, before and after removal, or for olfactory neuroblastoma, which again, the pre-op surgical, but that's not volume, the removal of the tumor. In these cases, the important difference in such cases in malignant tumors is that we cannot use, at least there is a significant risk if we use the nasoseptal flap, if it's close to the tumor, as one risk the seeding of the tumor into the operative cavity. Complete removal and the reconstruction using multiple layers of fascial latta. And of course, I'm not here to say that I'm not a neurosurgeon to start with, and I was lucky to work with some excellent neurosurgeons, such as Dr Van Furth in Holland, and I learned from him that a lot of these tumors can only be done via craniotomy, such as this tumor, which was removed in that via craniotomy. And now, I hope I'm running in time. We have to talk about, as we go, we talked about looking at the sella and then going superiorly at the transtuberculum and transplanum approach. And then we have to go sometimes laterally, which I hinted at earlier. And laterally, this is the image that we will find in the, you heard it earlier. We have the medial and lateral pterygoid plate, and we have the V2, the open of the V2 and the median nerve. The infraorbital fissure, and this is the endoscopic image of the area as we go laterally. Now, in order to get this kind of lateral access, it depends, of course, a lot on the anatomy of the patient. And in some cases, the sphenoid sinus may be more pneumatized, and also the distance between the posterior part of the septum and the wall of the sphenoid may be anteroposteriorly larger. So not only the lateral extent, but the anteroposterior extent of the sphenoid sinus can define how much lateral extent you can get in a very similar way to the frontal sinus, that when someone operates laterally, it's not only the anteroposterior distance of the frontal sinus, but the lateral distance, the interorbital distance that defines your axis, and the same is in the sphenoid. But having said that, in many cases, in most cases, one has to go via medial maxillectomy approach in order to maximize the lateral access. So in this way, one can have the front door, as they say, to Meckel's cave. And he can access an area that otherwise is very difficult to access. These slides are anatomical dissection performed by Jacopo Dallan, and from the book of Jacopo Dallan and Professor Castelnuovo on the carotid artery, which I use daily and I find very useful. So to go further, because I think we had the anatomy earlier, this is a case that was dealt with via I will stop it. That was dealt with via a transpterygoid approach to the Meckel's cave and Cavernous sinus. And basically, it was an interesting case. It was a 39-year-old female which was referred to us with progressive cranial nerve palsies. Now, the thing is that because of the location of the tumor, as you can see here, the location of the tumor at the area of the left cavernous sinus and the area of Meckel's cave with extension through V2 into the pterygoid fossa meant that for the neurosurgeons, it was an area that was deemed very difficult to biopsy. So the initial diagnosis was a meningioma of the trigeminal, and she was treated with radiotherapy. This didn't go very well. It didn't help, so the patient was referred subsequently for biopsy to us, which we did. As I said earlier, we would able, in this case, if we go back to the surgery, you can see she has a very wide open sphenoid. You can see it here with a significant anteroposterior and lateral distance of the sphenoid. That meant that we were able to go laterally without having to do initially medial maxillectomy. So we did the biopsy, or we did just a simple antrostomy. We were able to visualize the posterior wall of the maxillary sinus, the sella and the clivus, and then taking out the bone from the posterior wall of the father, the posterior wall of the maxillary sinus. We were very quickly able to find the foramen rotundum, as you can see here, and then localize the anterior part of the tumor. A biopsy was taken from that area. Now, there was no need for reconstruction, but it was done. Now, the biopsy surprised us. The biopsy showed an adenoid cystic carcinoma So it was not a meningioma, it was a benign tumor, it was an adenoid cystic carcinoma. And it was discussed at the tumor board. The suggestion was that, as you know, of course, very well, that adenoid cystic carcinomas do not do very well in themselves with single radiotherapy or chemotherapy. So it was to try to remove as much of the tumor as we could, and then that would be followed by proton beam radiotherapy. So that's what we did by going back into the same operative
surgical excision.
And the first part is, in this case, as we knew we'd be doing a bigger surgery, we had to prepare an nasoseptal flap to prepare for the reconstruction. We removed material from the previous surgery. We drilled the root of the pterygoids to get the lateral axis that we wanted. And we removed, of course, the inflamed mucosa from the area, and we opened up the bone in the front door to Meckel's cave. We know we are working laterally, in this case to the carotid artery, so we were using a Doppler in order to localize it. Going back into the removal of the tumor, we are here at the front door, and just as you can see medial, lateral to the carotid artery, we're using the Doppler to identify it. And then once we know our limits, we're working lateral to that. We're lucky, I think, that the bleeding was not significant during surgery, and we're able to get almost complete macroscopic removal of the tumor in the area of Meckel's cave. You can see laterally the dura, and you can see the intraoperative navigation slides, how far we're able to go. The dura from the middle cranial fossa and the tumor of the cavernous sinus and Meckel's cave being removed, all the way posteriorly, the most posterior limits of the tumor. And the reconstruction here was done with an nasoseptal flap and some fat. And of course, we did the post-operative MRI the day after the surgery. And this is, let me see if we have it. Again, it confirmed the macroscopic removal of the tumor, and this is the post-operative endoscopy. And the patient recovered very well. This is the full pre-op and post-op MRI. You can see the area of the tumor, and here, and the macroscopic excision. So, with that, I think I will try to stay in time. And I'm happy to get any questions. Thank you very much.
Thank you, Christos. I'm just looking at the Q&A. I don't see that we've got any definitive questions. Ashok, would you agree?
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
in the meantime, Christos, can I ask you, you showed a really nice dissection there of a macroadenoma. Can you tell us how your technique might be different for a challenging Cushing's microadenoma?
Yes, yes, of course. I think in Cushing's, it's a very nice question. In Cushing's, the one thing that we have to aim for is a complete resection, and that is an absolute must if possible. And the problem with the Cushing, of course, is always localization. Before surgery, it's sometimes because it's microadenomas and can be even smaller. Recently, we had a case where it was smaller than 1 centimeter, actually, and it was very difficult to localize. And there is a number of techniques such as sampling, venous sampling from both cavernous sinuses to help with localizing the area where the adenoma is located. And also some techniques using a PET, CT. But I think the one thing is preoperative localization, which can be very tough. And intraoperatively, I have been using the last couple of years the technique of Professor Rokade with diving surgery, using the flushing of the cavity with the rinsing fluid from the endoscope, which I find to be really helpful in examining the cavity and removing any final remnant. It both helps to dilate the cavity, much like doing a cystoscopy. Dilate the cavity, provide hemostasis, and help remove any remnants of the tumor. So I use this diving surgery, Rokade technique. And yes, so I try to be more radical if possible and localize better and use the diving technique. Yes.
That's nice.
What's your experience?
Yeah, I think the real challenging ones are the ones where you can't even find them because they're so small. They're either very far out towards the cavernous sinus and small, or you've actually got to feather the gland with a blade to try and open it up. But yeah, I like your technique of using the hydrodissection. I'll ask one further question on this. So our previous speaker was talking about the importance of ENT surgeons being involved in this as well. And it is, I would agree that's critical. And I think everybody here would agree that that's critical, but it's not necessarily what's happening internationally. We know lots of centers where neurosurgeons do endoscopic skull base by themselves and do it very well by themselves. How do you feel we as a specialty can encourage and ensure that we have a footprint in this type of surgery ongoing?
I think this type of webinars are very good in that respect, that they bring together ENTs and neurosurgeons. The same apply for courses, for panels where people talk together. And I think up to a point is also a matter of personal, let's say, relationships which develop within different departments between ENTs and neurosurgeons. I don't think it can be done in a kind of normative way, that there can be some national requirements for the cooperation. I think it can be done mostly in a more voluntary way and by better education of both ENT and neurosurgeons and meetings which bring them together.
Great, Christos. That was a lovely talk and well answered questions. Thanks very much.
Thank you.